Thank you very much for having me here again. Today, I'm going to talk about Y90 in the present future of HCC treatment. Okay, these are my disclosures. I'm going to start my talk with this spicy narrative review recently published in Journal of Hepatology by Riyad and his colleagues. So this paper is basically to answer the question, is a red stack for early HCC curative or not? It's quite a spicy question, right? Especially to your GI oncologist or hepatologist colleague, there's still a question whether it's can he regard it or Radistag as a curative option or is it palliative like TACE? So this paper is a narrative review to answer this question. So narrative review, but I do like their logical flow. Okay? To answer this, you have to know what is the curative treatment for HCC? Okay? We have to know the context. So is transplantation curative for HCC or not? What about surgical resection? Is resection curative or not? We generally think resection is a curative option for HCC. But there is some condition, some context that we have to figure out. Okay? What if the resection margin was positive? Okay? What if the patient died of complication after surgery? What if there's micrometastasis in the remaining in the remaining liver or lung? It's not curative in this situation. Okay? I mean, after surgical resection, some fraction of patients couldn't benefit from the resection because of these issues. But still, we generally think resection is a curative treatment modality. Okay? What about ablation? Is ablation curative? What if the tumor is 4 centimeter, 5 centimeter? Okay? So when you talk about curative treatment, you have to understand the context. Okay? So what is the cure in the context of HCC? We generally think percutaneous ablation is a curative option. So why is ablation curative? Because we need context. In a selected patient, less than 3 centimeter, less than 3 nodules, in this selected patient, ablation has ability to achieve complete pathologic necrosis. Not always, but the chance is very high. The chance is high enough. And it has optimized the technique. And when you apply the optimized technique, we can expect generalizable, consistent outcome across operators. And its toxicity is also acceptable. It's actually safer than surgical resection, which is another curative option. And it's a 5-year overall survival rate. When it comes to early HCC, it's 60 to 80%. Okay, so in this context, we generally think ablation is a curative option. Okay, so what about a RADSEC? What about radiation segmentectomy? Is radiation segmentectomy curative? We also need a context. So in a selected patient, okay, less than 3 nodules, less than 3 centimeter, or less than 5 centimeter, RADSEC has the ability to achieve complete pathologic necrosis. Okay? When you look at the recent RADSEC papers, RADSEC, its 2-year local tumor progression rate is between 5 to 15%. But when you look at the ablation paper, either RFA or microwave ablation, especially the large data set, their 2-year local tumor progression rate is quite consistent. It's generally about 15%, 10 to 15%. It's very consistent. And in the same line, when you compare this local tumor progression rate after RADSTAC, you can get, you can regard this is a curative option when it comes to local tumor progression rate. 5-year overall survival rate, the data are quite scattered, but in general, in radiation segmentectomy literature, 5-year OS rate is about 60 to 80%. Same with that of RFA papers. Median PFS or TTP data are relatively sparse, but it's overlapped by that of RFA paper. We have optimized technique, radiation segmentectomy, and by applying this optimized technique, we can get generalizable, consistent, reproducible, replicable outcomes. And also, this is very safe. So Given these factors, we can conclude that Radixact is a curative option. So, think about efficacy and safety of surgical resection, percutaneous ablation for early HCC. Okay? From the efficacy standpoint, surgical resection is better than ablation. From the safety standpoint, ablation is better than surgical resection. Both are curative options for early HCC. So the bar is here. Okay? If radiation segmentectomy made a cut, we could say Radixact is a curative option. Okay? Radixact, based on the literature, its efficacy might be better, or at least as good as that of ablation. I emphasize the local tumor progression rate, right? From the safety standpoint, Radixact is as good as ablation. So Radixact made a cut. That's why we drew a conclusion that Radixact is another curative option along with percutaneous ablation and surgical resection. So this is the logical flow of the narrative review by Riyad and his colleagues. So I like this logical flow. So this reflects the present status of Y90 radioembolization in the context of HCC treatment. So let's move on to the future. Intermediate stage. We all know intermediate stage HCC is very heterogeneous. It's very difficult to capture an image of intermediate stage HCC, but I'd like to spectromize intermediate stage HCC depending on their tumor burden. From the left side, you can put a few small scattered tumor, 3-4 tumors, less than 2 centimeters. These are BCLC-B patients. On the other hand, the right side, you can see very massive, multinodular, bilobar, aggressive HCC. This is another type of BCLC-B patient, right? You can categorize the patient tumor burden based on tumor size, number, and localization or diffuse distribution. So BCLC guideline recommend liver transplantation for the left side of the BCLC patient. Relatively small burden, where we can expect good outcome after local liver transplantation. They also recommend the TACE for small to medium burden HCC. And then on the right side of the BCLC-B, the high burden, aggressive, bad biology, now the trend is to use systemic treatment as the frontline treatment, right? When you look at the Japanese guidelines, they recommend TACE for every substage of patient. And now they start to use systemic treatment for right side, high burden, bad biology BCLC-B patient. But they also recommend surgical resection for the middle columns, right? Tumor burden is not very small, it's moderate, maybe massive if there's a single large tumor with some satellite nodules. But once it's localized, they have recommended a surgical resection. Okay, I think we can consider Y90 now for this tumor. Right, not very small tumor has a burden, but it's still localized. Now we can consider Y90 radioembolization. So when this is one of the examples. This is a retrospective study from Seoul National. We collected a patient with a large tumor with some satellite nodule, but good liver function, no extrahepatic spread, of course. And then you can see the more than 1/3 of the patient experienced radiologic CR. Almost all have radiologic objective response, but there's no change of child Pew class, MELD score after treatment, no post-embolism syndrome, which result in median hospitalization time of 1 day. Okay, this is a good example how we can use Y90 in high burden BCLC-B but localized HCC patient. Another context is advanced HCC but still localized tumor, right? Locally advanced tumor, VP123 and unilobar tumor we can consider Y90 as a first-line treatment. This is another paper from Seoul National. We retrospectively collected a patient with a unilobar tumor, VP1 to 3, very good liver function, no metastasis. Then we analyzed those patients, and tumor observed dose is, of course, the most important factor. And when you look at this graph, patients who received a high enough dose, 600 gray or even higher dose, showed almost 50 months of median overall survival. This is a very impressive number given the current paper about immunotherapy. Okay? The left panel shows patient course. There's a group of patients with VP1 to 3, they received Y90, and then when you look at this part of patient received resection, curative resection after treatment. Can you see? You can see. Okay, so this fraction of patient received resection, some received transplantation. These patients did not receive any treatment after one session of Y90 because there is no evidence of disease, right? And then I want you to focus on this part. Very small fraction of the patient received atezolizumab because this is a retrospective study. Most of the patients received Y90 before the introduction of atezolizumab in Korea, right? So if you combine this outcome, this potential with modern immunotherapy, we may expect better outcome. So in this context, what is the outcome of systemic treatment after for patients with very localized but advanced HCC? In Brave 150, when you look at the In Brave 150 paper, they present the patient overall survival for patients with macrovascular invasion. They present the overall survival of extrahepatic spread. They present the data of macrovascular invasion and or extrahepatic spread. But the patient of interest to us, that what we wanted to know is overall survival of patient with macrovascular invasion without extrahepatic spread. There's no data. In the same line, checkmate, no data. But I happen to do this network meta-analysis, and you can see, you can statistically estimate their survivor, right? I estimate the median overall survival of patients with macrovascular invasion without extrahepatic spread, and their median overall survival is about 2 years, versus our paper is about 4 years, right? It's a big difference. Of course, my paper is retrospective data, selection bias, but the gap is still very huge. This is a very strong message where we can use Y90. In the same line, we can do this spectrumization. We can put this advanced HCC in the spectrum. Left side, relatively, sorry, so I'm gonna skip this. Okay. So we can also consider combination therapy. In BCCB, right side, we now consider checkpoint inhibitor as a frontline treatment. There are multiple clinical trials and replace trial, but also from relatively left side of BCC, we are testing Y90 plus combination therapy. We also consider TACE plus combination therapy. So the key is the relatively left side, relatively localized tumor, we are now actively testing combination therapy, while right side is now the area of system treatment. So if I simplify this, right side, immunotherapy, left side, relatively localized tumor, combination therapy. But there's a caveat here, right? I think this is one of the most interesting data from Emerald-1 trial, which tested TACE plus checkpoint inhibitor, okay? They compared the disease progression pattern after Emerald-1 enrollment, okay? They compared TACE plus checkpoint inhibitor group versus TACE alone group, and then the most common disease pattern across both treatment arms is new intrahepatic region, okay? So think about the patient. These patients are initially TACE eligible patient. You did TACE. You can expect some new region in the liver, right? It's very expectable. And the patient have regular follow-up every 3 months. What is the nature of the new hepatic region? Is it like a 10 centimeter size tumor, or is it PVT? No, it's generally very small tumor, can be managed by local regional treatment. Okay, so we can do the same thing with advanced HCC. Right side, we can do immunotherapy. The left side, we can do combination. So these are the list of ongoing clinical trials when it comes to Y90 plus checkpoint inhibitor. You can see that the inclusion criteria. So the Emerald Y90 up to VP2, no extrahepatic spread. Stratum, Asian multicenter trial, up to VP3, no extrahepatic spread. Rowan trial, tumor volume up to 35% of the liver, up to VP2. So we are testing Y90 not for advanced HCC in general, but we are testing Y90 for relatively localized advanced HCC. So in summary, Radaseg is now a new curative treatment for early HCC, and we are generating data about ablative Y90 for large HCC plus minus PBT. And then we're also testing Y90 plus checkpoint inhibitor for advanced but localized HCC. Thank you for your attention.